heart health. Heart health is so important in so many ways, and without further ado, I'd like to introduce Dr. Claudia Soler-Alfonso. Thank you. Give a round of applause.
Okay, good morning, everyone. I want to first thank the AGSD for the invitation and all of you for being here this morning. I know yesterday was a very long day, and really appreciative of your time and really ready to share with you some of the conversations we have as GSD doctors or GSD providers with other specialties, in this case, with our cardiologists that help us taking care of you. This talk is very family-based oriented, and my goal is to give you the tools that you'll need to take, hopefully with you in your pockets, to have better conversations with your cardiologist. I'm not a cardiologist by training, but I definitely interact a lot with cardiologists, not only for GSD, but other metabolic disorders. So I hope this will be helpful for you in those conversations in the long run. And short, I hope you can see me. I will do my best to tiptoe, but before we start, I'm not going to be talking extensively about Pompe disease. There's a concomitant lecture right now with Dr. Kishnani, I believe in ballroom number 2. So if you have Pompe disease interest, you want to talk more about Pompe, please make sure to find yourself over there, find your way. I'm just going to mention it very briefly here. I have some conflict of interest to disclose, but nothing related to this particular lecture today, and these have been reviewed by my institution as well. So we'll go through some very key concepts. I know many of you are already very familiar with what GSD is, but we will then translate those concepts into the heart, and we'll be digging more into the heart energy, how the heart uses glycogen, and why some GSDs spare the heart and some other GSDs affect the heart more. We'll also go into reviewing some of the signs or symptoms that patients with hypoglycemia will experience that will also affect the heart. And then I'll review the different aspects of the heart issues or cardiovascular issues on patients with type 1A, very briefly Pompe disease, type 3, and other GSDs associated with heart disease. So here is the way we like to explain this to families about what glycogen is. So glycogen is a store in the liver mostly, and is the form of a storage of sugar or glucose in the body, and it's kept mainly there as a source of energy for either prolonged fasting or periods of illness. When we have an enzyme missing in that process of storage and reuse of that glycogen, then we can end up with a glycogen storage disorder. So you think about it like a traffic jam, with glucose being what's being carried in that traffic, and the enzyme being the traffic police. Whenever we have an enzyme defect, we have a traffic defect, and we may end up either having problems with glycogen storage in the liver, glycogen storage in the heart, or glycogen storage in the muscle, and in some of the GSDs with a mix of those organs together, depending on where the enzyme is expressed. So the organs then will use that glucose and glycogen differently. In the liver, it's interesting because when you look at the liver in real time, the liver has this very pearly appearance, and that kind of pearly appearance is actually glycogen. So the liver has this immense capacity of storing glycogen massively, and it's doing it because it's responsible for maintaining those glucose levels in the blood at a real time. So it's able to also export glucose out of the liver to maintain glucose in the blood actively. But the heart and the muscles are not equipped to do so. They store glycogen to keep it inside, to use it immediately for contraction and activity. These cells are very energetic, so they resort to glycogen and immediate use of glycogen, so they don't need to export it out, and they're not responsible for maintaining your glucose levels in the blood, but to use that glycogen for their own purposes. So before we go deeper into the heart, it is important to know the heart roles, and I know many of you are familiar with this, but some may not be. So there are really important roles of the heart as an organ in our body. It really recognizes the pump, but it's actually two pumps in one. The right side of the heart is sending blood to the lungs to pick up oxygen, and the left side is pumping oxygen-rich blood to the rest of the body, and that oxygen-rich blood is also transporting glucose. It also has its own built-in wiring. So it has this ability to stimulate the cells electrically by itself, to maintain a coordinated pace through time, and it's also a tireless muscle. It's able to beat up to 100,000 times a day without resting. And because of that need, it also has its own cardiovascular system, so it has its own arteries that will continue building the blood supply to bring oxygen and glucose to it through the coronary arteries in the heart. So as I hinted earlier, the heart is a consumer of glucose, but it's not a producer. So it's like having a restaurant and being able to use everything within the restaurant, but it's a restaurant that is never going to deliver food anywhere else. So you think about it that way, it's easier to understand what happens when we don't use glycogen effectively. And when we look at this in more detail, some of the things that the heart will do when the glucose enters the blood cells in the heart, it will enter through gates that we call transporters. In this case, we call them GLUT transporters. And immediately, an enzyme called exokinase will grab those glucoses and will link a little bit of phosphate to it. And it's sort of like a key to hold that glucose into the cells and doesn't allow that glucose to escape anymore or go out anymore. And then immediately we'll route it to different organs in the cell for energy production and to store it. The hearts don't use an enzyme called glucose-6-phosphatase, which will do the opposite to exokinase. It will remove that phosphate, and that's the reason why it's not able to contribute to the blood glucose maintenance. So that is essentially a key concept there. So the heart is built to take in glucose and use it, but it's not able to export it out. So I want to open the room a little bit and ask, what are some of the common signs or symptoms you may have experienced when you have hypoglycemia? So we often hear that we feel sweaty, we may feel confused, but I want you to think about your heart. So if you are now thinking about the times you have experienced hypoglycemia, had you felt anything in your heart? How about chest tightness? Any hands up for chest tightness? How about palpitation of skipping a beat? Right, some of you. And how about just the heart beating faster? A few of you, right? So yes, well, we often spend a lot of time, especially upon diagnosis, educating families on how to recognize hypoglycemia. So we will hear about the common symptoms: sweatiness, dizziness, fatigue, anxiety, nausea, blurred vision, even confusion, difficulty concentrating in older kids. But we often also hear the feeling of racing heart, palpitation, and chest discomfort. And this is because when our glucose drops in our body, we get dysregulation by hormones that will try to raise the blood glucose. That includes hormones like noradrenaline, cortisol, glucagon, and those will also stimulate the beating heart to pump faster, aiming for the blood to get to critical organs, in particular the brain. So it's common to have those signs or symptoms. But I also see that many of you didn't even raise your hands, right? And we know that this lack of symptoms is a common problem in patients with GSD because they experience so much hypoglycemia that they become unaware. So their bodies are very used to these hormonal responses. So you may not even feel or hear your heart telling you that there is anything wrong or any of the other symptoms come into consideration. So why some GSD types spare the heart and some others will affect the heart more? Well, we talk about the fact that depending on the enzyme that is expressed and where the enzyme is actually expressed in the body, you may have more or less. And we already talked about an enzyme called glucose-6-phosphatase, which is the enzymatic defect in people with GSD1A. And GSD1A will not impact the heart primarily, but it will have other cardiovascular manifestations, but not primarily affecting the heart. GSD type 9, particularly GSD type 9 alpha, also known as phosphorylase kinase deficiency, is also an enzyme that the heart doesn't use, so it's not affecting the heart per se. But as you see, the other types of GSD, particularly type 3A, type 2, and Danon disease, will have high expression of these enzymes in the heart, and therefore the heart will be immediately impacted by the lack of the action of those enzymes and give you signs or symptoms almost immediately. So we had talked about how the heart is a muscle, and muscles depend heavily on that proper energy storage and use. And in certain GSD types, glycogen or a normal material will build up inside the cells, and it will cause the heart to work harder or fail to pump normally. And over time, then, what the heart will do to try to compensate is it will try to increase the muscle mass. We call this an enlarged heart, and in a better way, we call this hypertrophy. So we know that this can occur over time. And one important thing to mention with hypertrophy is it can be completely silent. It may not give you any signs or symptoms. You may not feel really sick with shortness of breath or fatigue or any other signs or symptoms until it's truly enlarged and more dangerous. So surveillance for these type of things is important because we want to catch this hypertrophy early so we can provide treatment if treatment is available. So before moving into the specific types of GSD, I thought it would be a good idea to mention some of the tools that we use to interact with cardiologists, and the cardiologists will offer to you when we send them and refer them to them. The majority of these tests are painless, mostly in a way accessible to use, and the majority will be covered by insurance if we use the right coding in diagnosis and the right justification for the test. So they help us looking at the heart in different ways, and they can give us the full picture. And of course, the first and most line for any sign or symptom will be the physical exam that we will do with each one of you in our clinics. And with the simple listening of the stethoscope, we may be able to pick up on murmurs or a normal rhythm. So you'll have already a screening test for your heart when you see your doctors. But we can also resort to doing echocardiograms. Echocardiograms are an ultrasound that shows the heart beating live, and then we can take different measures about the dynamics of the heart and those pumps in the heart, the valves of the heart, and they can help us determine if there is hypertrophy or enlargement. We can also do EKGs, which is the test where you get the stickers on your chest, and then you measure the electrical activity of the heart. And in these, we will be looking more at the actual rhythm and the synchronicity of the heart to ensure that the heart is not failing in doing so. And if we don't see anything abnormal there, but if the patients are still complaining of palpitation, chest tightness, or any other symptoms, we can do an extended EKG for 24 or 48 hours, in which the patient will wear the wires for this period of time, and then it will be analyzed to tell us. And it's actually also more in real life because the patients will be active doing their usual things, so it can give us more information over time. And sometimes we will also use a cardiac MRI, which is a way more detailed scan that we will get from the echocardiogram, and it can tell us a little bit more about the structure of the heart itself, and it can tell us a little bit more about the scarring of the heart, and a little bit more about the tissue characteristics of inflammation over time. So these are the usual tests you will see cardiologists ordering, but they can also order some blood tests. There are a couple of a simple blood test chemistry that is available at almost every hospital. They are very specific blood markers, one called CK and another one more specific for the heart, CK-MB. And this tells us about the turnover of the cells, meaning premature breakage of those cells, so those cells breaking before they're supposed to, obviously, and being injured or damaged. So when they break, they release these chemical markers into the blood, and then we can measure them. And over time, they can tell us how good we're being about protecting the heart and providing the heart with enough energy. Lipids and metabolism labs are also very important. We know the cholesterol, triglycerides can accumulate in the coronary arteries, so we like to look at those in detail. And other more specific markers like troponin or pro-BNP are very sensitive markers for heart function that also over time can tell us a trend and help us understanding if interventions, in particular dietary interventions with different types of GSD, are taking effect, and how aggressive we need to be with certain interventions if we see those are really helping with the heart function. So let's dig into GSD1A. Again, this is a condition that is not directly or primarily impacted by the enzyme defect in the heart, but it has secondary complications. And We already discussed that GSD is caused by glucose 6-phosphatase deficiency, so we're not able to pull out that glucose 6-phosphate after glycogen is used, and it becomes glucose 6-phosphate that becomes trapped into the cells, and we're unable to convert it then to free glucose. And this enzyme is highly expressed in the liver, the kidney, and the gut. Therefore, we will have impact on those organs. But as the heart as a whole is communicating with all other organs, it will have some consequences later. And the very first manifestation we are always mindful of is systemic hypertension. So this is the most common cardiovascular complication in GSD1A. The median onset of true hypertension is around 15 to 17 years, but we've seen it and much earlier in patients as well. And it's tightly associated to the progression of renal disease. The kidney is actually very important for maintaining blood pressure. It has a system called the angiotensin-aldosterone system that communicates very closely with the rest of the body to maintain the blood pressure. It's sort of like a sensor. So when we have chronic kidney disease, then we're going to start developing issues of maintaining appropriate blood pressure levels. An important consideration here is that referral to nephrology or the kidney doctors should be in place to help us looking at the kidney function closely. When we start seeing protein in the urine at a microscopic level, it may be important to begin treatment. Even if the blood pressure levels are not significantly high, we know that these medications called ACE inhibitors can protect the kidney over time. But it's also important to avoid beta blockers, so medications like atenolol, propranolol, and so forth, because those medications can mask hypoglycemia. They don't let you get tachycardia and some other things, and they can also mask some of the hormonal responses you will get with hypoglycemia. So we tend to avoid beta blockers if we can in patients with systemic hypertension at GSD1A. A second complication that we look closely is pulmonary arterial hypertension. This is a rare complication, but reported in patients with GSD1A. And what that means is that the blood pressure in your lungs is higher than the pressure in your heart. And that's not desirable because they had to have a different relationship so you can pump the blood out of the lungs. And the mechanism for this is not well understood. We think that there are some abnormal metabolites there, but we know and we think, based on the few reports in the literature, that it's related to metabolic control in patients with 1A. So the better your metabolic control, the lower the chance of developing pulmonary arterial hypertension. And it should be recognized early because there is specific treatments for it. There's medications that can help. So even though it's rare, it should be screened for, and we'll talk about how to screen for those things and how often. And the third big pillar of patients with GSD1A is the risk of atherosclerosis, which is the formation of cholesterol plaques in the coronary arteries. And it's been an ongoing concern because we know many patients with GSD1A have very, very high and very severely high levels of triglycerides and what people will call bad cholesterol, LDL cholesterol. So it's always been an ongoing concern that patients may be more prone to develop these plaques in the heart. But so far, the evidence tells us that they may not be at a higher chance than other populations, and that may have to do with the fact that other abnormalities may actually have a protective effect in the heart. This is an area that is evolving, and the more we continue collecting patients, and I think the clinical trials that are happening on the side with GSD1A are going to generate more data on this over the years. Patients are also aging more, thankfully, so we may be able to understand the risk of atherosclerotic disease in more detail. But again, it seems that as of now, the population risk is very similar. So what should we do? How should we monitor these things? So anytime you come to the doctor, you should get your blood pressure, and that should be the same with cholesterol metabolism checking, so lipid profiles during infancy and the first childhood years. But then the recommendation is to begin screening with echocardiograms at age 10 years old, mostly because of the risk of pulmonary hypertension. The kidney-related monitoring is recommended in adolescence and adulthood, but we start much earlier in our patients, and I think the majority of doctors here will agree. Most patients are getting referred in between the first and second year of life just to begin conversations of what to look for. And then during adulthood, just a traditional cardiovascular risk assessment for atherosclerosis formation will be what it is there. But again, this monitoring and surveillance is going to be just a recommendation. It's what it is. It's a guideline. This has to be tailored, and it has to be customized, personalized in a precise manner to your needs. So it depends on what you're showing and your interaction with all these values. It will determine how often we will need to do these things. And we know that the most important cardiac treatment is metabolic control. I think someone asked about what metabolic control is. We really, it's a question that is still haunting us as providers of metabolic diseases. So what do we call metabolic control? And if you allow me to dare to make a definition of this, I will say that is balance. So balance in between the best numbers we can get with the most optimal treatment, and balance with your lifestyle and considerations of how much this disease is impacting your life, how often are you coming to the hospital with hypoglycemia. So we're able to balance those things and meet in the middle. We should be able to say that you are in metabolic control or fair metabolic control. And that has to do with the frequency of feeding, the dietary optimization, and a very close and tight relationship with an experienced metabolic dietitian. And also a good understanding of how much cornstarch is good for you. Under treatment as well as over treatment is a big issue, and that interaction only comes with time and by developing that relationship with frequent monitoring, glucose logs at home, as well as weight management and optimization of the diet. So that's the best way you can manage that cardiovascular risk when you have GSD 1A. I'm going to move very, very fast through type 2 Pompe, mostly for those that want to learn about it. You hear it all the time. So I thought it would be good just to sail through it. As I mentioned, there'll be more dedicated topics during this conference on type 2 Pompe. The enzyme defect here is expressed mostly in the muscle cells, the heart cells, and what we call the skeletal muscle, so the rest of the muscles of the body. And it's expressed in something we call the lysosome, which is this compartment in the cells that is in charge of breaking and recycling different chemical materials in the cell, some to be reused and some to be wasted out. So when we have problems with this particular enzyme, acid alpha-glucosidase in lysosomes, we can end up with Pompe disease. It's also inherited as many of the other GSDs, with parents being carriers and passing the non-working copy to their children, having a 25% chance with every pregnancy. And there are two forms of the disease, the classic form and the late onset form of the disease. And as mentioned, the problem here is lysosome storage accumulation. The first type of Pompe disease is classic, is the one we fear sometimes the most when we see in patients in the neonatal intensive care unit, when we get called. These patients in the first years of life, and they will be very, very flaccid. They will have very significant low tone. Their tones are going to be very enlarged because of that glycogen accumulation, as well as their hearts will be significantly enlarged on the chest X-rays. So it can be an easy diagnosis to recognize if you're familiar with the disease. Most pediatricians are familiar with it. The ability to recognize early this disease will allow us to implement enzyme replacement therapy, which is available for it. And then the late onset form of the disease, which is a little less common than the neonatal classic infantile form, will present with more subacute symptoms of muscle weakness. People will start experiencing fatigue, problems walking, and it can take years even for patients to achieve the diagnosis. So it can be very slowly progressive. But enzyme replacement therapy can also make a difference for those patients. And enzyme replacement therapy has been in place since 2006, and there's been significant developments on different approaches for that enzyme replacement. And we also have now something called substrate reduction therapy. Along with that, some medications that can also help reducing the amount of glycogen in the lysosomes. The important recognition, the fact that early diagnosis makes a difference for enzyme replacement therapy, push this condition to be in the newborn screening programs in the US. So we're actively screening every single newborn in the majority of the states with the goal of implementing the enzyme replacement therapy right away. There are different predictors for the response to that enzyme replacement therapy related to the patient's immune system, how early we do it, and so forth. And as I mentioned, there is emerging gene therapy approaches that are coming, hopefully to be available in the next 3 to 5 years for this particular condition. So there's a lot of action on Pompe. Every time I get to I do mostly liver-based GSDs, but every time I pick on Pompe, I feel there is something new to learn. So that's really a very brief and very quick review, but I hope you can get a good idea of what's going on there. And the other big one is GSD type 3, also known as Cori or forced disease. And in this one, we will have a normal debranching of the glycogen. So some of the things we do when we extract glycogen out of the cells is to start debranching these 3 glucoses out. And this enzyme will, that will be lacking here will not allow that to happen. So we may end up with very abnormal glycogen that can be very inflammatory to the heart cells, the muscle cells, and the liver. There are distinctively 2 types of GSD, type 3. Type 3A will affect the liver and the muscle, and that's the most common type of type 3A GSD. And then type 3B is considered to affect the liver only and spare the heart. So those patients will present with more symptoms of hypoglycemia and ketosis, but those are kind of like the 2 big population of patients we will have. Well, naturally, they will have cardiomyopathy or sickness of the heart in around 30 to 60% of the patients. And that will present with thickening of the walls, enlargement of the heart. The age of onset of this cardiomyopathy can be very early in childhood, but it may worsen in adulthood as well. And they may also have EKG abnormalities or rhythm abnormalities. These rhythm abnormalities can be serious, and they may be putting patients at risk of sudden death, so they need to be looked at closely. They're not common to cause these kind of issues, but known to be a consideration. And we know that specifically in this particular population, treatment really impacts. And when I say treatment, I'm talking about the dietary intervention. So we're going to talk a little bit more about that. But before doing that, we're going to talk about the surveillance. But naturally, as we know, the disease affects the heart from the get-go. Patients are going to be monitored with echocardiograms, EKGs, and blood tests at least once a year. And of course, depending on how we see the patterns of those, we may have to do more frequent assessments. And a word on GSD type 3B, as I mentioned before, is considered to affect the liver only, but there's still recommendations to do at least a baseline echocardiogram at diagnosis and to look at it at least every 5 years. It's not completely clear that all patients will have liver-only manifestations of the disease, so that's also an ongoing conversation. The majority won't show any heart issues, but there is also considerations related to diagnostic uncertainty. This is probably true for older patients that are reaching adulthood. Many may not even have actual molecular confirmation that they had type 3. Type 3 liver-based or also known as type 3B can be very similar to GSD1A in many ways. So there might be patients that may have the wrong diagnosis. So that uncertainty is also a good point to address with that echocardiogram at least every 5 years. And also in patients that have molecular confirmation and we know the specific gene mutation or gene change, we're not able to have an understanding yet of what mutations will predict affectation of the heart versus others. So for that reason, it's still recommended in guidelines to offer echocardiograms, not so often as type 3A, but to maintain the surveillance. And let me jump back to the diet, which is really a key factor of interactions with patients with GSD type 3. The key concept is that dietary therapy aims to decrease glycogen accumulation in the liver and the heart and the muscle cells, but we also want to increase the availability of those organs to have other sources of energy. And those sources are usually coming from fatty acids that ultimately become ketones, and that's another way our body can maintain energy levels, in particular the brain. So the traditional therapy didn't work because we know that when we tell people to eat carbohydrates at all times to avoid hypoglycemia and prevent fasting, that would also increase insulin levels, it will promote more glycogen storage, and it will also make the body use less fat and ketone metabolism. And so we know that the potential consequence is even enlargement of the heart. So high protein will then provide other sources, and proteins are made of something called amino acids, and those amino acids can be taken by the cells, and by chemical reactions, you can make glucose out of that. So that's called gluconeogenesis. So the fact that we are increasing our intake and providing other sources can really impact the way our heart is receiving energy. And the same goes with the higher fat and the ketone production as described. So we know that over time, there can be significant potential cardiac benefits when we implement this high protein diet. It can really improve cardiac energetics as patients grow older. So besides the high protein diet, there's been different approaches and combinations on mixing high protein with diets that are high in fat. We call those high protein, high fat diets, or even going to the other end and doing diets that are mostly based on fat with very minimal carbohydrate intake. We call those ketogenic diets. So there are ways that we can push metabolism in one direction or the other. But so far, the best and most accepted diet is the high protein standard approach. What we know from some of the studies, the small groups of patients that have been treated is that by increasing the protein intake by 25 to 30% of the total calories, that's around 3 grams per kilo per day in children, you can definitely impact the heart function significantly by decreasing the size of the heart as well as those values like CK significantly. So it's very important to take these to your interactions with your local providers. You ask about your protein intake. If you have type 3 GSD, how much protein should I be eating every day? And most of the time, we're not able to achieve this by just the regular intake from food, but we actually have to outsource to supplementations of protein. So many of you are familiar with some of the usual protein supplements out there. But most of the time, you have to also outsource to take extra supplementation along with the starch. So high protein diet is really what's recommended in our guidelines. And lastly, I'm going to go briefly through some of the other types of GSD, GSD type 9, Danon disease, and GSD type 15. Danon disease is one in which the heart is critically affected not only by the abnormal glycogen, but the protein made by this gene is also important for the structure of the heart. It affects boys more than girls, and these patients can have massive hypertrophy of the heart with severe heart rhythm problems. Unfortunately, these patients could also present with intellectual disability and also retinal problems. So they will require very extensive surveillance with echocardiograms, EKGs, more often than other patients. There is no specific treatments, and the dietary interventions don't tend to be very helpful because the other component of the structure of the heart. So many patients with Danon disease may end up requiring a heart transplantation later in life. So it's a quite severe disease. And just a word on GSD type 9 and GSD type 15. GSD type 9 has different types as well. The most common type we see in our clinics is PHKA2, also known as alpha, and this is X-linked, so it affects boys more than girls. This one does not express itself in the heart, so we don't have any major cardiovascular concerns on patients with type 9A. And I will ask, again, if you have type 9, what type do I have? Do I need to be seeing a cardiologist? Because I've seen many patients with type 9 alpha that are recommended to have echocardiograms once a year when they really don't need it, so that can also impact your bills and can help you financially, also cutting on things you don't need. So knowing also what is not needed is important in this kind of aspect. And type 15 also is one that affects the heart significantly. And this is glycogen deficiency, which is the first start of glycogen storage. So patients could present with severe cardiomyopathy, and it may be the first sign or presenting sign of the disease. So they will need also close surveillance with cardiologists. And moving away from this, in reality, almost every single one of these GSDs will deserve a full hour conversation. There is a lot to say here and there. But what are some practical tips that you can take with you? So we talk about some of the common signs or symptoms during hypoglycemia or high ketone levels. And those include hunger, sweating, shakiness, and so forth. And it's going to be sometimes hard to distinguish if this may be also related to your heart, based on what we just learned about heart disease. And I will say that, yes, there is a lot of overlap on those, but if you're having problems with fainting or loss of consciousness, and you're checking your glucose, and your glucose and ketones are within normal limits, that should be an immediate consideration to seek cardiology attention. Constant chest pain, pressure or tightness can also be an important sign to keep in mind. Any problems with blue lips, fingernails, or any swelling of the legs, severe shortness of breath, any problems with frequent skid beats, all those, if they persist over time and they don't correlate with your glucose or ketones levels, then should be brought to the attention of your primary providers to seek an immediate cardiology evaluation. And of course, if these are more serious, you should come to the emergency department and seek help immediately for those. So this is one way that you may be able to ascertain one or the other, but monitoring is always going to be key to correlate those signs or symptoms with your glucose and ketone levels. And I thought it would be good too, based on my own interactions with patients, what questions you should ask your care team. So what do I need to know about my heart in relation to my GSD? So you may want to take this to your next appointment or take notes. But some of the questions are about diagnosis, so empowerment on what type of GSD I have. Do you know if my GSD affects the heart? What are we doing with this kind of problem here? How often do I need an echocardiogram, an EKG? And what do I need to do for that? Am I, if I'm already under surveillance, when was my last echocardiogram? Sometimes because we spend so much time working on the diet and monitoring and hypoglycemia, some of these ancillary surveillance get pushed on the side and they may not happen on a rapid clinic appointment. So it's good to ask when was your last echocardiogram, check on your portals as well, when was the last time you got checked. Do I need something else like a Holter monitor? Do I need a cardiac MRI? And am I getting the right medications for my heart disease? So if I already know that I have established heart disease, do I need any other medications? Do I have pulmonary hypertension? Should I be taking something else for that in case I had GSD1A? So those are good questions to ask in general. Am I able to do exercise and lifestyle based on my cardiac status? I think obviously exercise is very important and we always push for that, but is that something that is even okay based on how sick my heart is? So it's important to know that. And how about the school and work? Do I need to tell people at school anything different about my heart? Most of the time the answer is probably not, that what they need to know is already related to hypoglycemia, but do I need to have anything else in mind? And family planning is more about anyone else in the family that may be affected by the GSD. But I would also tell you that in medical genetics, we know that around 6 to 8% of our patients may have a second diagnosis that may not have been recognized. So it's important to always keep your eyes open, because if something is not following the usual pattern, we should be extending our genetic testing odyssey to ensure the patient may not have another primary cardiomyopathy gene affecting the heart function. So it's always important to know what are the heart implications in the genetics for other family members that may be at risk. And I will leave you with all that. Again, it's a lot to take in less than an hour of the review of the heart issues with GSD, but I'll be happy to answer any questions from here on. Thank you.
If anybody has any questions, please raise your hand and I'll get to you with a microphone on my way.
Thank you. Hi, Rebecca Reba from Connecticut Children's. Thank you very much. That was wonderful. One of the questions I struggle with a lot, and you just mentioned at the end, right, that some people have a second genetic diagnosis. And so I have some patients that have clearly familial hypercholesterolemia, a relatively common mutation where their LDL levels are quite high, kind of independent of their metabolic control. Do you think about kind of treating with statins in those situations from a cardiac protective perspective, since we don't know everything about GSD?
Absolutely. That goes along with that very good trend of thought, right? Like, I think familial hypercholesterolemia is as often as 1 in 500 Hispanics, for example, right? So that's you'll see more often than Down syndrome, right? So you think about how often we think about rare diseases and we get this definition of rare disease, there are things that are quite common and we see them in front of us all the time. So I will definitely extend a panel for cholesterol metabolism disorders or even a whole genome sequencing these days. Because yes, then you can consider starting treatment, and that will also eliminate that variable from your dietary management. Because if you know this patient has a familial predisposition and another mechanism, and you manage that, that may give you that balance of metabolic control, bringing us to that ascertainment of how good we're being at controlling the disease overall. Sure.
I was just wondering if you're aware of any heart transplants I know it's done in Danon and potentially probably somebody with Pompa has had it at some point, but are you aware of heart transplantation in any of the other GSDs?
I personally haven't had that experience. The majority of patients have a more subacute presentation with GSD, so the majority don't make it to have frank heart failure to the point that will require heart transplantation. And if you happen to have type 3 and we are able to optimize your protein intake, we know that the heart function will improve, and we've seen that in the small cohorts of patients as well as in clinic, that even sometimes the ventricular hypertrophy improves to the point that it completely disappears. So I don't know if the other GSD providers have seen anyone with transplants, but I haven't particularly.
Anybody else? Don't be shy, raise them high. All right then.
Thank you so much.
Thank you.